our senior glaucoma expert, Dr. Rajul Parikh sir. Sir is well known for his advanced glaucoma surgeries, especially along with cataract procedures, and is the best person to give us the best tips for cataract surgery in presence of glaucoma. So over to you, sir.
Yeah, thanks, Padma. Okay. So, good morning, everyone. So,
Can we have the slides, please?
yeah.
Sure, perfect.
So, the talk I will divide into two parts. One, the surgical decision making, and second, in glaucoma patient is very imperative that which lens you choose. So, because the cataract surgical technique would be more or less same in open angle glaucoma, there are some few things you have to remember in angle closure glaucoma, but decision making, because in glaucoma patients, whether to do only cataract surgery or you have to do only glaucoma surgery first or combined surgery, that is more important. So, yes, they do coexist because glaucoma prevalence is high. As age increases, the risk of glaucoma increases, and cataract is of course age related. So, is of course both coexist, and that's why we should know. And in angle closure, the risk of complications is little more in cataract surgery, but open angle glaucoma is not a big issue. So, the pre-operative assessment of a glaucoma patients in view of cataract is very important. So, a thorough examination, especially looking the corneal status, which we do all the time, but conjunctival status is very important, because if you are doing combined surgery, then whether to do trab or any other surgery, that's why conjunctiva is very important from the glaucoma point of view. Pupillary dilatation, and then most important thing when it comes to glaucoma assessment, structure and function, because depending upon the damage, I would decide that only cataract surgery I'll be doing, or I'll be doing combined surgery or a trabeculectomy first. So, this is very important. And secondary causes. The secondary angle glaucoma like NVI, uveitis, they would require special care from the glaucoma point of view. So, if the patient is, now I don't use pilocarpine, but there are patients who are on pilocarpine. So, if you are planning cataract surgery, at least try to stop pilocarpine a week or 10 days before. Otherwise also, what you can do, that intermittently keep dilating the patients if the patient is on chronic pilocarpine, that helps keeping the pupil mobile. There are a few examples. You get all, if you dilate, you can see pseudoexfoliation. Now, this is a traumatic glaucoma. You see there is a clear area here which suggests that most probably patient has a pre-existing PC rent, and which he had. Structure function, as I mentioned, because that would decide my management plan. So, decision, you have three options: only cataract surgery, two stage, when glaucoma surgery would come first, and combined surgery. So, and why is important? Because the goal is totally different. When you do cataract surgery, the objective is vision should improve and healing should be very fast. With clear corneal, we ask patient to go from second day or same day they can go for the work. But glaucoma surgery, I don't want the trap to heal very fast, whatever surgery I do. And my primary objective to preserve whatever the patient vision has. So, only cataract surgery, patient is early glaucoma, IOP well controlled within 2 medications, and now with the recent experience in PSC or early PSCG, if the patient is more lens thickness or high lens word, I would consider only cataract surgery even if the patient is on 3 medications. On other hand, you can see this patient, there is a macular split on size 5. Here, my primary objective is to make sure that glaucoma he should not get wiped out. So, I would do a trabeculectomy first and cataract later on after 3 to 4 months. Combine all intermediate cases, patient is on 2-3 medications, borderline IOP, where cataract is a major issue, or patient is not tolerating medication properly, or logistic issues, sometimes logistic issues do come. And now with the advance of mix, even patient with 2 medications, if they don't want to use medication, I would consider phaco mix. And mix, we have lots of options, I'm not going to discuss that. But again, the mix advantage is that no post-op recovery, in a sense that patient can start work from the next day, just like cataract surgery. So, that's the advantage, especially if you are doing ab internal goniotomy, bang, KDB, eye stand. GET sometimes can cause more hyphema and may require a delayed recovery. So, planning as a on table glaucoma patients, especially with advanced glaucoma, no sudden decompression. Pre-operative, if the pressures are too high, I would give mannitol, not in every patient. Avoid tight speculum, especially in the angle closure, because they have a shallow orbit. The risk of positive pressure is very high, and you will keep getting iris prolapse from the wound. A limited hydro or careful hydro with large axis in angle closure, that is really helpful. Avoid anterior chamber fluctuation, and if you are doing trap, releasable or adjustable suture. When do combined surgery, now with two sides, I do clear corneal, temporal and superior trap. Fornix limbus, your choice. I do fornix from the beginning. If you are doing limbal base, is absolutely fine. Mitomycin, when you are doing combined, I use mitomycin all my cases unless the conjunctiva is very fragile. And there is a reason World Glaucoma Association consensus very clearly says that the combined, the glaucoma surgery success rate is not great. So I would like to use mitomycin to make sure that my trap works better. One side, two side, as I mentioned, your choice. Limbal fornix, your choice. But if you are using mitomycin, fornix makes more sense because you can go away from the limbus and put mitomycin posteriorly. And if you think that the glaucoma is a pressing issue, go ahead only with the trap. Don't consider combined surgery because trap alone has a much better success rate compared to combined surgery. Post-operative, again, it's not like cataract. Even if you have done only cataract surgery, you have to make sure that IOP doesn't fluctuate very high. So you have to take more care unless only cataract surgery in a normal eye. If you have done trap, then make sure that you look the conjunctiva, the corkscrew vessel, because in that case you may have to give 5 FU injection antimetabolites. You may have to do the release the early, may have to teach patient indirect massage. The trap management is always, you have to be more aggressive and more careful. So this is one of my combined patients after 6 weeks of trap. You can see very nice bleb. Now I'll just give few examples, and I have not deliberately kept the cataract surgery video because that would be, everybody is going to show cataract surgery video is going to be same. As I mentioned, in angle closure you have to be little careful, otherwise cataract surgery is more or less same. What extra you have to do? So this is one of the patients, 55-year-old male, angle closure glaucoma, but if you look the refractive error plus tail, axial length of 20, this is nanophthalmos. And nanophthalmos with angle closure with cataract, they have very high risk of UV effusion and complication of supracarotid hemorrhage. So what extra care you have to take? That is what I am more interested. So you do a prophylactic sclerotomy with the sclerectomy. You can do two side, you can do one side. In this patient I just decide to do one side, but this is what is important. 3.5 millimeter from the limbus, you make a 3 millimeter, go up to the supracarotid space, and you can leave it. And this patient I also had done the sclerectomy before I did the sclerotomy. So you can remove the partial thickness sclera, because the sclera is thick, that is the reason patient gets UV effusion. So that you have to be careful. Second case, this patient had a failed trabeculectomy and we had planned the cataract surgery. So in this patient, you can do retrap, but this patient we decide to do the MS glaucoma along with the cataract. So what you have to do, cataract surgery I finished. When you have a pseudophakic eye, it makes sense to put the tube behind the iris, so it remains away from the cornea. The risk of corneal decompensation reduces. In most of my cases now I make a scleral tunnel, so you don't have to use sclera. 4 millimeter from the limbus, and here I gone little deep, so I can go behind the iris. And you can see this is I have constricted. Even if you don't constrict, is fine. And you can see that the tube is here behind the iris. So it makes surgery very, in long term, the cornea remains much safer. This is third case, 68-year-old female, POAG, she converted to PACG, which is very common. That's why gonioscopy, routine gonioscopy is very important. We did iridotomy. Subsequently, her vision was 6/6, but she was completing a visual care and she had significant cataract. There was a likely progression. She was on 4 medication, but on ASOCT, the lens was 850 micron. So we decided to do only phaco IOL and not combined surgery. She was on 4 medications, and after 5 years, she's only on 1 medication, and that's why in PAC and early PACG, if the lens voltage is very high, you can consider only cataract surgery and keep trap for later on if at all required. So the conclusion, the first part, of course, surgical decision making is individualized. You cannot have an umbrella that this patient this surgery, but individualized approach is what is required. Now the second part is more important, which IOL you will use in glaucoma patients. So we have a multifocal trifocal IOL, then we have true EDOF IOL, and we have monofocal IOL, and we have modified monofocal IOL, and toric. So I'll just go step by step. Multifocal trifocal, the studies are very clear that the glare, halos, and contrast all are more. The contrast sensitivity is drastically reduced in glaucoma patient, and glaucoma patient anyway have a reduced contrast sensitivity. So you should be very careful. I would say that definite glaucoma patient you avoid multifocal trifocal lenses. So because of these all three reasons. Not only that, they also have an effect on visual field. So if you look this study, the phakic IOL, monofocal IOL, and this is trifocal multifocal IOL, the sensitivity is drastically reduced, which affects your clinical judgment. So this is one of the reasons, but main reason is the contrast sensitivity drastically reduced in glaucoma patients, and multifocal trifocal will worsen that. So you should avoid that. True EDOF, again, if you look the studies, the contrast is worse in even in myopic eye with all true EDOF. So ideally, I would avoid the true EDOF in definite glaucoma patients. Right, modified monofocal, which is the IHENS and Clarion, they are much better tolerated, and I'm using that for last 7-8 years in most of my glaucoma patients. Very good results, and studies also says that the glare contrast sensitivity does not get affected. The results are as similar to the monofocal IOL. So modified monofocal is my choice in glaucoma patients. If you are doing combined, I would not recommend toric IOL because the IOL can get rotated and the things become more difficult to manage. So the monofocal lenses if you are doing combined surgery. Post trabectomy, if eye is stable, you can think of toric IOL, but you have to be careful because I had bad experience in couple of patients. Even I had done trap 1 year ago. So you have to be careful. If you are doing angle closure, post trap, you may get surprises. So I would avoid anyway. I would avoid trifocal, multifocal, but you should be careful. I would avoid that. So all glaucoma suspect, if the disc damage is not much, you can consider, but as a practice, I don't recommend. Pseudo exfoliation, again the small pupil, IOL centration can be issue. The monofocal modified is better. It should be case based. Better to err on the side of caution. So rather than be aggressive about the newer lenses, I would say that monofocal or modified monofocal is a better choice of selection in as well as IOL is concerned. So there I end my talk. Thank you.
Thank you, sir. I think it was a amazing overview, and thank you for covering also the lens choice. I think two most important things which of course came across. One was that in this beautiful case you have shown when patient was already on 4 medications, just doing phaco in angle closure with the lens fault is high and the thickness is good. Yes.
Because both presses the angle.
Right.
And once you do that, the angle space opens up.
Yes.
So they work just like extra trabecular flow.
Right,
so
sir.
The thing is that if your trabecular network is damaged,
Damaged, yeah.
you may require trab later on.
Correct.
But you can always go after 3-4 months.
Correct, right. So it is always better to put it in the second go if it is required. Yeah.
That progression, but the disc was not very bad.
Correct.
If the same patient had 0.9 bipolar,
Right.
I would have definitely considered.
Right.
The disc damage was not bad.
Right.
There was progression, but the fluid was very still not bad. So definitely in those patients I would do only cataract.
Sir, one last question is like for patient who has very advanced glaucoma, has already undergone a trabeculectomy, pressures are under control, has undergone trabeculectomy in the past, is 0.9 plus cupping, and now requires only cataract procedure. What is the possibility of having a wipeout phenomenon? And yeah.
If you look, the main issue about this wipeout,
Right.
how the people have defined split fixation.
Right.
So most of the time people have defined split fixation on size 3, which is not ideal.
Okay.
So the size 5,
5.
macular lobe,
Right.
which I showed,
Right.
if there is a 1, 0,
Right.
that is the way you should define wipeout.
Right.
In that case also,
Hmm.
when I was in Bangalore, we had 35 patients
Right.
But when you're doing surgery, you should know how to operate.
Right.
So if you are confident about your surgical skill and take proper care,
Right.
then why not?
It's very
See,
rare.
if you have too much of AC fluctuation,
Correct.
if you, otherwise what happens in lots of centers, when you're doing combined or post-lab, if you're giving block,
Right.
the block is given by veneer, then they
Right.
put excessive
Right.
pressure,
Right.
some places they put the pinky ball.
Right.
Those things should be avoided.
So any
if
form
you
of
take
pressure
care of
fluctuation should be avoided. Right.
care,
Right.
then the risk of wipeout is
Yeah. Even the highest risk will be 2% is what you're saying. So compared to, so
should
that
be
is,
explain the patient.
yeah. So it is required for basically patient counseling.
Put the care that in expert
Right.
hands.
Right.
So if you know how to do cataract surgery
Right.
properly,
Right.
then it's fine.
Right. Perfect.
Sir, I have a question. Like in the case of nanophthalmos, like how many days in advance you like to do sclerotomies or on table, same
On
time,
table.
same time?
Same side. So people recommend two.
Hmm.
I most of the time do only one. So because when I'm doing right eye, it's much easier for me to do infratemporal. If I'm doing left eye, infranasal or one. But ideal recommendation is two side. And you do a partial sclerectomy. Basically, the sclera is thick. That
Yes.
is the main reason.
Yeah.
So you do sclerectomy, and yet when you do sclera.
Yeah. Yeah.
Just very nice presentation. Congratulations, really, you covered everything. I'm just highlighting that we should differentiate between low tension glaucoma and other case of glaucoma in the choice of the IOL, because usually low tension glaucoma affect the central part. So even the enhanced monofocal in these cases are not recommended. Usually, if we found that the central part of the field is highly affected, so monofocal, simple monofocal will be better visual performance for the patients, better than even monofocal plus.
Whenever doubt, just or on the side.
Just or err on the side of one. Thank you, sir.